everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Today, I have the pleasure of welcoming Dr. Abigail Wooldridge. Dr. Wooldridge is an assistant professor and former faculty fellow in the Department of Industrial and Enterprise Systems Engineering, where she directs the Human Factors in Sociotechnical Systems Laboratory. Her research focuses on engineering sociotechnical systems to support team performance and improve outcomes, particularly in the healthcare and health-related settings. Dr. Wooldridge also has courtesy appointments in Health and Kinesiology, the Seibel School of Computing and Data Science, School of Information Sciences, Beckman Institute for Advanced Science and Technology, Coordinated Science Laboratory, and National Center for Supercomputing Applications at the University of Illinois, and the Department of Biomedical and Translational Sciences at Carle Illinois College of Medicine. She is an Arches Faculty Fellow at OSF Healthcare and a Research Associate at the Mayo Clinic. In addition to all this, she has also worked in industry with experience in process improvement consulting, decision support, and surgical scheduling. Her work has focused on surgery, obstetrics and gynecology, internal and family medicine, trauma care and emergency medicine, all of this resulting in over 100 peer-reviewed publications in Human Factors Ergonomics as well as healthcare journals. She and her trainees have received numerous awards both nationally and internationally. A very good afternoon to you, Abby, and welcome to the podcast today.
Thank you so much for having me. I'm really excited to be here.
Of course. Ever since we touched on the topic of your work, the socio-technical systems, I've been looking forward to having you on, so I'm so excited to have this episode here today. So Abby, just to get us started, please tell our listeners a little bit about yourself, including kind of where you grew up and your training background.
Okay, that's a great question. So I grew up primarily in Louisville, Kentucky, not Louisville, not to be confused. We say it Louisville, like you either have a mouthful of marbles or have been drinking a little bit of bourbon. And I, went through high school and was trying to figure out what do I want to do in college. And at that point in my life, I really thought I was going to go to med school. And actually, I wanted to be a surgeon, believe it or not.
Mhm.
I always like to have backup plans on backup plans. So I thought, okay, well, a traditional pre-med major might be something like biology or chemistry, but it's kind of hard to get a job with those degrees unless you go to grad school. And it's possible I wouldn't get into med school or would change my mind. So let me look for something that I could have a job right away. And I landed on biomedical engineering. And it met most of the pre-med requirements. However, that first semester of undergrad, I, one, was not doing so well in chemistry lab. I did not enjoy the wet lab environment. And
Mhm.
two, I was shadowing a physician in an ED and came to the rather disturbing realization that perhaps I don't want to do things with blood. Yeah,
Understandable.
it happens. And rather than find a way to deal with it, I thought, there's plenty of other ways for me to have the kind of impact I want in my career, which was really to help people be healthier, rather than being one of the clinicians making people healthier, providing the care. So I looked around and there was this field of industrial engineering that I was kind of interested in. They talk about things like quality and efficiency and productivity. So I switched majors, I think within the first 6 weeks of undergrad, and was trolling along thinking this is wonderful. I will be an industrial engineer. I'll work making healthcare more efficient and better so that more people can have access. I did a little bit, I worked at a consulting firm as part of my undergraduate degree doing Lean Six Sigma process improvement. The first project I was on was in the operating room and sterile processing, thinking about inventory, where to put the supplies you need in surgery.
Right.
And in my last year of my undergraduate degree, we were required to take Introduction to Human Factors and Ergonomics. And I took that class. I had no idea what it was, other than this is a word you see on pins that they're trying to sell you, or desk chairs that they try to sell you that will make you more comfortable. And I
Mhm,
got really interested in this idea of we can study how humans work and what
mhm,
makes it possible for humans to work better. And given that I knew I wanted to be in healthcare, which is fundamentally about humans taking care of other humans, it just really fit. So I pivoted a little bit. I spent some time kind of at the intersection of mathematical modeling and human factors and ergonomics. And then when I went to graduate school for my second master's and PhD, I switched over to
mhm.
human factors specialization. And you did mention I had a little bit of a detour along the way. So I
Yeah.
did my undergraduate and master's of engineering at University of Louisville in Kentucky.
Mhm, mhm.
Then I went to University of Wisconsin-Madison and worked with Dr. Pascal Carrion, who is a really seminal figure in healthcare safety and human factors and ergonomics, did a master's degree.
Mhm,
Then
mhm.
I worked for about 3 years at one of the hospitals in the Miller School of Medicine down in Miami, Florida, where
Mm.
I managed decision support and surgical scheduling.
Wow.
And so I spent some more time in the OR there, kind of getting to understand a lot more about what goes into making the operative day successful, not just what happens in
Yeah.
the surgical suite. And then I decided I wanted to do research and be a faculty, so I went back and got a PhD at University of Wisconsin-Madison with Pascal.
Got it. Okay. Well, I have to say, quite an impressive journey, and I appreciate you sharing that with us because I think it's important for people to know that there are, as you correctly pointed out, there are so many ways in which we can have an impact, or the type of impact we want to have in the world. And so it's good to be able to explore these things. And it's also good to find out what you don't want to do pretty early, like you did,
Yeah.
and switch, tracks. I've pivoted so many times in my own life and career that I'm but later in my life and career, so I'm beginning to understand how that happens and why it's actually necessary. So I will tell our listeners also that Dr. Wooldridge is currently the secretary for the Society of Surgical Ergonomics, and I will say that surgery's loss was our gain in the Society of Surgical Ergonomics and the whole human factors world because I think the work that you're doing, Abby, truly, affects how we do things, as you said, and ultimately the goal is to improve the care for our patients. So I appreciate, everything you're doing and for sharing your journey with us again. So
Thank you.
yeah, you're welcome. Now, I guess I want to know a little bit more about your field of expertise, which is socio-technical systems. And I'll tell you why. So, before I was a part of the SSE and began meeting people like yourself, like Dr. Susan Hallbeck, and Dr. Tara Cohen and others, I didn't realize, that there's this whole field of human factors and ergonomics work and research. And I hadn't heard about socio-technical systems until I met you. So most surgeons, when we think of ergonomics, we think of physical ergonomics. So I would love it if you could kind of shed light on this topic for our
Yeah.
audience.
Yeah, of course. So I'm going to come back to your question about sociotechnical systems and what is that. I'm going to step back for a second and say, I know you've had a lot of really wonderful folks on the podcast before me who have talked about human factors and ergonomics, like other areas of the discipline.
Right.
So human factors and ergonomics, the big field is focused on the science to figure out how to design systems that work for people, right? So if you think about that big picture definition from the International Ergonomics Association, we tend to divide our scientific discipline into three subdisciplines. We have
Mhm.
the physical ergonomics field, which I think, as you alluded to, is what most surgeons think of. Dr. Hallbeck has, been a leading force in the area, particularly in surgery, for a long time. Then we have cognitive ergonomics, which I think you had Dr. Patricia Todovich on to talk about recently. And then we have this third area, which is in the US typically called macro ergonomics, or if you're in Europe or the UK, you might hear it called organizational ergonomics or systems ergonomics.
Mhm.
So sociotechnical system theory is the theoretical backbone that underpins macro ergonomics, which says, yes, humans might be interfacing with a physical device. They might be interfacing with a physical environment that's shaping their biomechanics. Yes, we have things that impact cognitive work and how people process information and make decisions and handle interruptions. And also, the broader environment, including the physical environment and the technology they're working with and the other people involved, also impact how folks are doing work.
Ah,
So, a sociotechnical system then is really the best defined as looking at the root of the word social and technical or technological. It means that we're thinking about the technical system folks are working in, what technologies they have, their physical built environment, the noise, the layout, as well as the other people that they're working with in the social system. And we're trying to jointly optimize the design of both the technical and the social subsystem to ultimately improve outcomes, which, commonly in healthcare, we're thinking about patient outcomes, but also ergonomists are thinking about outcomes for the workers themselves, like the surgeons, the nurses, the anesthesiologists, the techs.
right. Oh, wonderful. Thank you for that very easy to understand explanation and kind of laying those components of the field of human factors and ergonomics out for me as well as our audience. So let me start then by asking you, how did this sort of area of research or work in HFE field start? Did it start in industry or was it always kind of primarily based in healthcare? And could you give us sort of examples of how socio-technical systems come into play in these different work environments, for example?
Sure. So, sociotechnical system was a concept that was developed at the Tavistock Institute back in the late 50s, early 60s. And it came about from a landmark study actually studying coal mining, if you can
Mm,
believe it. So, not healthcare at all. So, they were looking at a change of process from a short wall method of coal getting to a long wall method of coal getting. Basically, coal miners working in a team where they're working in one small area together to do their work versus going to a longer method where they have less interpersonal interaction. And they showed that this simple, quote, quote,
mhm,
change had a major impact on the social organization, teamwork, collaboration across time,
mhm,
physical space, and the kind of production or process stages of coal getting. So this is coming about in the 50s and 60s in the UK. It infiltrates the US perhaps a little bit later. In the late 80s and 90s, we start seeing folks like Hal Hendrick writing in the Human Factors and Ergonomics Society publications about the design of organizations and the design of work. And in 1989, Pascal Carrion and her advisor, Mike Smith,
mhm.
published the balance theory, which is the framework that I use in all my research and underpins the systems engineering initiative for patient safety model, which we've chatted about and I can chat about here,
Mhm.
that draws on theories of sociotechnical systems, job and stress, work design, and basically says all work environments include this idea of a socio-technical system where you have people at the center of things because at the heart of us we have humanist values, right? People who
Right.
are doing tasks in pursuit of goals, and while they're doing those tasks they use tools and technologies, could be as low tech as a pencil and paper or as high tech as an AI model to
Mhm.
predict probability of cancer, And they're using those tools and technologies in a physical environment as well as kind of an organizational, social context or setting that is ultimately also influenced by an external environment like rules and regulations at local, state, and federal government levels, as well as payment payers. So this has evolved. Pascal's initial balance theory was not specific to healthcare, right? It applies
Right.
everywhere.
Yeah.
But very rapidly in the early 2000s, she starts focusing in on healthcare because it's a very interesting setting where you have many people involved in work, right? You have physicians, you have nurses, all of the professions we've talked about, lots of different tools and technologies. And this very important at the time, you might remember in 99, you had the seminal To Err is Human
Yes.
report from the Institute of Medicine that highlights we have this patient safety problem. The
Hmm.
balance theory said that work system is what shapes outcomes. And in
Hmm.
healthcare, one outcome is patient safety. And as we've kind of pursued this line of research since then, it's also become very apparent we have a safety problem for healthcare workers as well, whether that's musculoskeletal risk, stress and burnout, and all of the associated kind of adverse health outcomes
Hmm.
for folks. So we have those two outcomes we're interested in improving. And then the last part of the SEEPS model we really like to emphasize is after you see the outcomes that are being produced, you monitor and you have this feedback loop where if you want to make them better, go back and redesign the system and then see if you had an impact. So that feedback loop is for adaptation and learning. So that's kind of the historical background. You asked about some specific examples. Well, surgery is a really complex, interesting sociotechnical system in itself. You're in the operating room, you have a consultant surgeon or attending surgeon. You might have trainees, residents, or fellows working with the surgeon. You have the patient themselves who may not actually be contributing to work at that moment in surgery, but they were involved in things leading up to being in the operating room, consenting, confirming I'm having a knee replacement on my right side, not on my left side. You
Right.
have anesthesia, you have nursing, and all of these people are doing tasks that are not entirely independent. They're related to each other. So that communication and coordination is really important and very interesting, on top
Mhm.
of the issues of the physical environment and what technology is around. So it's a system of people, a social subsystem working with technology and an environment to produce outcomes like did we do what we were supposed to do for the patient? Working on a project related to breast cancer. Did we get
Yeah.
all the cancer out?
Wow. Thank you so much for that beautiful explanation because as you started explaining sort of the origins of the balance theory in industry and the early beginnings of the socio-technical systems approach, I could see, even before you kind of explained it, I was like, oh, I can see how this would apply to a medical or a surgical environment. So,
Mhm. Yep.
and it's interesting how you pointed out that underpinnings are also kind of in safety, but it's not just patient safety and outcomes, it's outcomes and safety of the workers as well.
Hmm.
So, with that explanation, I was wondering if you could share some work that you have been involved in and led that, applied, as you said, these principles to improving patient outcomes and perhaps also outcomes for the individuals participating in the system, like you said. Could be surgical, could be medical, but just, concrete example. And the reason I ask for that and how you did the research and what you found was because I want myself and other surgeons listening to this podcast to be able to understand how they could think about doing this kind of research and collaborating with you and others to do this type of research. And we will be right back after this short message. If you're a surgeon or proceduralist finishing your OR days with neck pain, back pain, hand symptoms, or just feeling physically drained, I want you to know something important. These problems may be common, but they're not inevitable. Most of us were trained how to operate, but we were never taught how to operate for decades without accumulating preventable strain or reducing the risk for a career-ending injury. That's why I created the Surgeon and Proceduralist Career Longevity Program. a fully virtual hybrid program that combines small group learning with individualized ergonomic analyses using your own work videos, AI motion capture software, and surgeon-specific recommendations. Just to be clear, this isn't generic ergonomic advice. It's a personalized approach designed around your body, your specialty, and how you actually do your work. If you want to keep operating at a high level without sacrificing your body in the process, sorry, just edit out this last section. I'm going to record it again. If you want to keep performing at a high level without sacrificing your body in the process, or are looking to return to the OR after recovering from a minor or major injury, reach out to me at gita@surgicalergonomics.com to learn more. And now back to the episode.
Yeah. That's great. I think a really nice kind of more recent example comes from work that was part of my PhD student, Caitlin Dallas or Caitlin Hale Lopez, her
Mhm.
dissertation. And we were looking at maternal hemorrhage, right? So maternal hemorrhage is a very important issue. It's the leading cause of preventable death of pregnant women in the US. It's also
Mhm.
an international problem. And that morbidity and mortality rate is in childbirth is unfortunately high, higher than it probably should be.
Yes.
So we wanted to understand from kind of a macroergonomic or sociotechnical system perspective what could be done. You know, there's all these wonderful checklists and toolkits out there that you can use to kind of anticipate which women might be at risk for hemorrhaging. But given that those exist and they're, very good, why are we still having this problem?
Right.
So we followed a really common strategy where we go in first and we understand what is the current situation. I think Pat mentioned this idea of understanding work as done, not just work as imagined. Oh, we draw a lot on that concept too. So we went in and we did observations in a labor and delivery unit, collecting data in a form that is guided by the SEEPS model. So who is doing what, using what tools and technology, where are they at, drawing sketches of the layout, et cetera, as well as interviews with the clinicians. And importantly, we were talking to the entire team, not just one profession. Again, healthcare is usually a team sport. So we did that. We went back and we used a technique that I developed in my PhD work called soup-based process modeling to understand how do those work system elements, those people, tools, tasks, tools, and technologies, physical environment, organization, and external environment shape work over time, and
Mhm.
ultimately try to understand as almost a proxy for an outcome for a patient or a worker, what makes work easier to do well in a way that is high quality and safe versus what makes work harder or more stressful, more challenging to do. And ultimately understood, okay, this is the process. Here are where barriers really are prevalent and what those barriers are. So, one big issue in a hemorrhage response actually turned out to be if the woman is hemorrhaging in the labor and delivery suite, they have access to really nice surgical lights. So that's a facilitator. They could see what was happening. However, if the woman starts to hemorrhage postpartum after she's moved from the labor and delivery suite to the postpartum unit at this particular facility, that's not equipped with really nice surgical lights. And that's a big problem. So we went through this process of identifying barriers and facilitators. The lights were a big one. Another big issue in the actual hemorrhage response, no matter where it occurred, is you call a code for hemorrhage and a bunch of people arrive.
Yes.
And then there needs to be someone who knows who these people are who can kind of help to coordinate who's doing what.
Mhm.
Sometimes the first physicians on that arrive are fellows or residents who don't know all of the nurses and all of the technicians. So who could that be? And we did some work trying to understand what role that should that person be, and then also are there strategies that could be used to help that person know who these other people are and what they're supposed to be doing.
Right.
So at that point, we also found out that at this particular facility, they had an alert or alarm fatigue problem
Mm.
where risk for hemorrhage was assessed when the woman presented for delivery, and it continued to be assessed. And then pop-ups would occur, and there's a sea of pop-ups, not just about hemorrhage. And so folks are just trying to do their work and they have a lot of pop-ups and they kind of
Right,
ignore.
right,
And the pop-ups also for hemorrhage specifically were not particularly well designed to accurately and quickly convey this woman is at high risk. You need to make sure you have meds available. You need to have the Bacri device in the room, and you should alert the blood bank, hey, we might need some blood before
right,
it happened. So we went through a process where we helped to think about ways to redesign those alerts and make them look different so that folks would redesign those alerts such that people would be able to quickly and efficiently get the information they needed, and
right,
also did some work further understanding at what point do those alerts need to be firing to try and reduce the number of alerts they were getting so that when they got one, they would know, oh, this is important, and I
right.
can quickly and easily understand what I need to do because of it. So that's kind of the start of the process. We did not go through and get to do an evaluation study after those changes were implemented. Unfortunately, part of the nature of research is sometimes funding runs out,
Yes, yes,
and you have to stop. But if we had, we would then go back and do a very similar process to what we had done before. Do
yeah.
observations, see what's working, do interviews or surveys or both, and see what's working, and then hopefully be able to see an improvement in a reduction of barriers the clinicians report, as well as a reduction in the number of hemorrhages that actually occur or hemorrhages that lead to a negative outcome.
Understood. So, like a lot of work in quality and safety, it is an iterative process,
Hmm.
is
Exactly.
exactly right. Okay.
Exactly.
Now, I know that this work, was published, and I'll be happy to attach the link to the publication for our listeners in the show notes so that, if anyone's interested in learning more about it, they can read it there. And I will also include Dr. Woolridge's contact info, meaning LinkedIn, so that if there are additional follow-ups or if people are interested in studying socio-technical systems, and using those principles for an issue that they have or a problem that they're interested in, this would be, is that a good way then to get a hold of you,
Yeah.
Dr. Goldridge? Great.
Yeah, that's great. LinkedIn is fine. I think also on my LinkedIn, there's links to my university page. So you're welcome to go there and reach out to my university email, of course.
Abby, could you share with our listeners, how someone who is interested in working in this field or interested in collaborating with someone like you, can start doing this? And, what are some, I guess, nuggets of advice you would give people just, trying to get their feet wet in this kind of work?
Yeah, that's a really great question. So I'll answer it a couple different ways, I think, or a couple different strategies you could use. So if you're interested in doing this kind of work, I think the best case would be find a partner. Either, me or someone like me would be ideal, right? One of
Mhm.
the things that I know from studying teams, including healthcare teams, is it's very rare, if not impossible, and I would actually go as far as to say impossible for one person to know everything that's needed. So I know human factors and ergonomic science. I picked up a little bit about healthcare as I've gone, but I'm never going to have the expertise of a clinician. So I need clinical partners to do my work and help me understand what the real problems are and how to talk to folks in a way that will make sense to
Mhm.
them. On the flip side, I think it's good to remember if you're a clinician wanting to do this work, I know some things that you might not know too, and together we'll achieve more. It's like there's no I in team, right?
Yes, yes.
So reach out. All of the faculty who are doing research generally are love talking about our work to anyone
Mhm.
who will listen. So if you reach out to us, we probably will reach back out and say, yes, please, let's have a time to chat. That's a great idea. If you are in a position where you might be a student or a trainee and you're wanting to learn more and maybe specialize in this yourself, find some literature to read. There's a really wonderful book, in my opinion, I'm biased, but in my opinion, that just came out last month. I have it here. It's called Human-Centered Design for Healthcare Safety, SEEPS in Action. And this is a wonderful resource. It's relatively short, not a horrible read, maybe 200 pages or so, written by Pascal that talks about the evolution of thinking about safety in healthcare, the historical background of sociotechnical system, macroergonomics, how human factors and ergonomics fits in human-centered design. And then there's lovely chapters that just have cases and cases of how we've done this work. So you could read this for, some inspiration as well as
Wonderful.
additional resources. But yeah, just really reach out. We love to talk to people, and we're always looking for ways to solve problems and make things better and safer. Whether it's, for a clinician, maybe you're having a really frustrating time at work, you're starting to feel burnt out, and you need some help thinking about what could we do differently rather than those individual targeted resilience exercises. Let's
Right.
actually approach it from a system and make real change that doesn't ask you to do more.
Yeah, well, thank you so much for sharing that wonderful resource. And, I think as the field continues to evolve, especially I indicate this to our sort of trainee members that are part of the SSE, this field is wide open for study. So seeking out people who are already doing the work, like Dr. Woolridge and other human factors experts, is a great way to use, as you heard Dr. Woolridge say, there is dual expertise and it can help advance healthcare safety and outcomes for our patients and ourselves. So do consider this as a career option. Abby, in the remaining minutes that we have, I actually do want to ask about something you just touched on, right? So, which is burnout among healthcare providers and
Mhm.
approaching that from a system standpoint. So I want to have you go back to the postpartum hemorrhage study that you were
Mhm.
elaborating on earlier. And I was curious to find out if you found any sort of issues with the system that was affecting providers themselves that was contributing to the poor outcomes. I know you mentioned various
Mm.
things like introduction of members of the postpartum hemorrhage team, etc. But what were some of the other things that you found that was directly related to kind of the physicians and other team members?
Yeah, that's a great question. So, one of the challenges we see often in any team response, including a hemorrhage response, I think possibly also in other surgical teams, is role ambiguity. So, this
Mm,
idea of either multiple individuals believe they should be doing the same task, and then that can cause conflict or
hmm.
tension, which then workplace conflict is one of those risk factors to develop burnout, or having lack of clarity of who is doing what. Right. So they're kind of related, but there's a slight distinction there. So that was one that we found. One that I also think is really important to remember from an organizational design perspective is you have to, if you're giving someone a responsibility, you have to make sure they have the resources, often time to do that. So when we were thinking about who is kind of the conductor of orchestrating that response and making sure all the resources that need to be there are there, the charge nurse of that unit actually came up as a really good option of somebody who could do that because they have a little bit more options in making resources available. They also do not have other care responsibilities at the same time, other patients they're supposed to be caring for. However, to make that possible, there are tasks that that charge nurse then needed to not have to do to be able to have the time and resources to go and do
Hmm.
that.
Hmm. Hmm.
So being mindful of this is also very important. And that is one of those systemic contributors to developing burnout, right? If you have too many job demands, too many task demands, and not enough resources, time, energy, space, people, et cetera, to do that, that imbalance can contribute to developing burnout over time if it continues and becomes chronic.
Right. Wow. That explanation actually is a prime example why, as you said, individual provider or care team member resilience programs. Yeah, let's do some more yoga. Let's, do these things. Don't have an impact, or a slice of pizza or a pizza party, etc. Don't have
Right.
an impact. That very eloquently shows why. Abby, I'm always surprised at how quickly the time just marches on as we're having these lovely discussions. And I just noticed that we're almost to the end of our time. And so I just want to take this last minute or so to thank you again for making the time, not just once where I had to pull out of the recording, but twice to make sure that we can get this episode recorded. And I'm so grateful for the work that you do and for sharing your expertise with us today.
Well, Gita, I'm so grateful for you having me and also just the work that goes into this podcast to bring folks like me and others, as well as clinicians who are doing this work to share it because it is so important. We still have a patient safety problem in this country and internationally, and we are facing mounting problems that are impacting our clinicians, our providers, our care team members as well. So, really, I think human factors and ergonomics has a huge role to play in
Yes.
solving some of those problems, but we cannot do it without this sort of connection that you're providing and space you're providing. So thank you for doing this too.
Of course, no, well said. And in the era of healthcare team member shortage, the importance of this work can't be overstated. The work that, all our human factors colleagues are doing as well. So, on that note, we'll end this episode. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.